This is a femtosecond assisted CAIRS procedure performed for keratoconus. We've already created the laser channel into which the corneal segment will be placed. Now I'm creating a second access point using a guarded diamond blade. This will allow us to both push and pull the corneal tissue. We gently open up the femtosecond created opening and the diamond blade created opening using this channel expanding device, which was originally designed for the intact procedure, which is really the predecessor to the CAIRS procedure. To allow further ease of entry, I use this blunt instrument which dials through the channel, opening up the potential space that was made by the femtosecond laser. We do this in both directions, and that way there's really no resistance as the corneal tissue is placed momentarily. The corneal tissue has been prepared by the eye bank. It is cut to the desired width and can be trimmed to a shorter arc length if desired. It starts off fairly hazy in the preservative fluid, but once it's integrated into the cornea, within a few weeks, it becomes almost transparent. I like to use a Sinskey hook to open up the roof of the incision, and then, using toothed forceps, slide the tip of the donor cornea into the channel. Once the tip is in, we're basically home free. It's a little fancy footwork here where you have to release the corneal tissue while holding it in position so it doesn't try to follow you back out again. But beyond that, we've now got pretty smooth sailing. Taking care not to let the corneal tissue twist in an undesired fashion so that it remains in the same arc length which was originally fashioned. We're sliding it in, and it just glides along that femtosecond created channel at 50% depth. One of the exciting ways in which CAIRS is a step beyond the intact procedure which preceded it is that 50% depth. With intacts, we had to go much deeper, 75 to 80%, in order to avoid extrusion of the segment. But with CAIRS, we can safely place it more anterior in the cornea, and that creates more effect. Having pushed it as far as I felt like I could readily, we're now using a reverse Sinskey hook to go under the corneal tissue, inside the channel, and gently pull it into the orientation, which supports the cone. Prior to the procedure, this patient had 6 diopters of astigmatism, which is a lot, and best corrected acuity of 20/25 -2. Note that the topography is upside down relative to the surgeon's view here at the operating microscope. After surgery, we achieved a 50% reduction in astigmatism and a 1-line improvement in best corrected acuity to better than 20/20 with a light pair of glasses or a soft contact lens. A huge success and very exciting for all involved.